If after he got off the field, into the ER, got his CT, x-rays, and whatever imaging they wanted, and an MRI, and they realized this is swelling already so much, he's got fracture blisters, let's wait. The risk of infection by cutting through or near fracture blisters is very high, because what else can happen? I heard it. Compartment syndrome. Now, with ankles, the risk of a compartment syndrome is less, but you can have it if you swell up right away, because then when you cut through the skin, depending on the extent of the fracture or dislocation, sometimes you can't close the skin. So if there's so much swelling and it's tight and you can't close the skin, with or without compartment syndrome, you may have to do fasciotomies, a whole other topic. But even without that, without compartment syndrome, if you can't close the skin, then you have to just approximate it, dress it, and then come back and then do a secondary closure. And so that puts you at risk for an infection and other complications. Other things that he's going to be at risk for: blood clots, assuming no nerve or vessel injury. We don't know all the details, but you're not going to be putting full weight initially. And so typically everyone has different protocols. Everyone does. Some people use heparin, some people use Lovenox. There's all sorts of oral anticoagulants. For healthy patients that are walking, you don't have to use a blood thinner. Sometimes you do. And oftentimes the best data right now is that people often switch to an aspirin, baby aspirin, BID, depending on the risk level. And all of that is the decision between the physician, the evidence out there for that particular injury, and the discussion with the patient. It's always a risk-benefit analysis. And that's the important thing.